What is alcoholism? What are the symptoms? And where is that threshold that you cross from from being a heavy drinker to actually being an addict? Hello cruel world, this is part 2 of a 3-part series that I'm doing about lots of different aspects related to alcohol and the relationship that alcohol has with psychiatric disorders and also with offending. This channel right here is A Psych for Sore Minds. It's the only YouTube channel that covers true crime and mental health and is hosted by a professional consultant forensic psychiatrist. I'm your host, Dr. Sohom Das. I assess mentally disordered offenders for a living so that you don't have to. So I act as an expert witness for criminal courts, and alcohol intoxication is very common in the patient group that I see, and also alcoholism is as well. In fact, there are more people that I see who have these problems than people that I see who are actually acutely mentally unwell. So in this video, I'm going to answer several questions, including the following. What is alcoholism? What's the threshold that gets it from a heavy drinker to alcoholism? And also I'm going to tell you how to make prison hooch. So sit back, get settled in, set your brains to stun, and welcome to A Psych for Sore Minds. So what makes somebody an alcoholic? Well, to put it in psychiatric terms, so I sound cleverer than I actually am, what are the features of alcohol dependence syndrome? And by the way, these features are the same for all substances. First of all, I'm going to name them and then I'll break them down one by one. So they are tolerance, compulsion, withdrawal, problems controlling use, continued use despite harm, saliency, reinstatement after abstinence, and narrowing of repertoire. Okay, so tolerance is fairly straightforward. I'm pretty sure you know what this means. This means where you need more of a substance, so more drink, to get the same effect as previously. Compulsion is like a very strong desire to use the substance all the time. It's like a strong urge. Withdrawal is a physiological and to a lesser degree an emotional state. So it starts when you stop drinking, and it includes really bad shakes, anxiety, headaches, vomiting, insomnia, sweating. Occasionally, if it's really serious, it can include hallucinations. And it can even lead to seizures, which can be deadly. So people can die from alcohol withdrawal. Also, you can get delirium tremens, known as the DTs. So that occurs in very heavy drinkers. So when they get into withdrawal, they vividly hallucinate and they have these delusions and they're utterly confused. On top of that, they can have a racing heart, high blood pressure, fever. So what happens is alcoholics often drink first thing in the morning, so they stop these withdrawal symptoms from coming on. Difficulty controlling substance use is when you basically can't stop when you should or when you want to and you can't say no. So for example, you might go to the pub just to have 1 pint, but you can't stop it. And before you know it, you're 10 Jaeger bombs in, you've lost your trousers and your wife is screaming in your ear. Continued use despite harm is what it sounds like. So people know that alcohol is ruining their lives physically, socially, mentally, but despite this, they carry on drinking. They just cannot stop. Saliency means when getting alcohol becomes the main thing in your life. It's more important than anything else. So for example, you might spend your money on alcohol rather than food, or you might start drinking instead of looking after your children. Reinstatement after abstinence. This means that even if you manage to quit for a significant amount of time, say several months, when you start drinking again, your level of drinking quickly goes back up to its previous level within a couple of days. And narrowing of repertoire means that the variety of drinking, where you drink, who you drink with, stops, it leaves. So you end up drinking the same type of drinks in the same place throughout the day in the same kind of pattern. So I've had a long battle with nicotine from smoking and vaping, and I've quit and restarted many times over the years. So I can certainly relate to some of these symptoms. Now, obviously I'm not suggesting that being addicted to smoking is anywhere near as physiologically or psychiatrically damaging as being an alcoholic. But what I'm saying is that I know what some of those symptoms feel like. I feel withdrawal symptoms. I feel that anxiety, like icy feeling in the middle of my chest. So to give you an example, I've not had a cigarette for a month and I still to this day get withdrawal symptoms. Another big one for me is reinstatement after abstinence. So I can go for months without smoking, and then I have like a big night out and I want to have one or two. So I'll buy a pack and then bam, I go back into the full habit within a day, and it's very frustrating. So after the break, I'm going to tell you about a real life case that I've seen of an alcoholic man who killed his cousin. That man was an alcoholic, and his victim, his cousin, was also an alcoholic. Very sad case, but very interesting. So, welcome to A Psych for Sore Minds. I'm your host, Dr. Sohom Das. I'm a consultant forensic psychiatrist, and I assess and rehabilitate mentally disordered offenders, or what the tabloids might call the criminally insane. I work in prisons, I work in courts and in secure psychiatric units, and I also act as an expert witness, so I advise judges in criminal cases across the country. This channel that you're watching dissects a whole range of mental health topics, some of which are related to offending and violence, like the case I'm going to tell you, some of which are not. And there are new episodes out every Tuesday and Fridays, so you need to subscribe. Otherwise, I'm telling you, you're going to miss out. Just remember, there's something for everybody on this channel. So after the break, I'm going to tell you about the case of Mr. B. So Mr. B was a case I saw in prison, and the case was for a parole board. They asked me to see him. He was in his late 30s at the time of his offence, which was murder, but he'd been in prison for almost a decade by the time I saw him. So my assessment was because the parole board wanted to know whether he was fit to be released or not. As I mentioned before, the victim was his cousin, and they were both alcoholics. They lived together, and from the sounds of it, they were just kind of drunk all the time. They had an argument which escalated to a physical fight, and Mr. B was knocked unconscious. And when he came round, his cousin was mocking him. So Mr. B had another whole drink with his cousin, went into the kitchen, picked up a large carving knife, came back, stabbed his cousin 5 times in the chest, including through the heart, killed him. In terms of Mr. B's background, he had some other minor offending, all of which was in the context of acute intoxication. So previous convictions included stealing cars, criminal damage, and damaging property. So nothing like hugely dramatic or shocking. There was some evidence of difficulties during his upbringing. So Mr. B had some traumatic experiences. He witnessed extreme violence, including his own father being kidnapped. And also once Mr. B was in a pub when he was just a kid, and that pub was petrol bombed. So obviously a lot of chaos, a lot of violence around him. So looking at the evidence, it seems that Mr. B had always been a heavy drinker since his teenage years. And in part, this was influenced by his lifestyle growing up. So like many of his family members used to drink alcohol, and also with his internal struggle to manage his feelings about anger, self-esteem. And also Mr. B had a hair lip, like a scar across his lips since childhood, which might have contributed. In terms of his psychiatric history, he previously had many episodes of alcohol-induced psychosis years ago. He had some mild depression, he had some anxiety, but nothing really that stood out to me, nothing particularly severe or serious. Mr. B had suffered from alcohol hallucinosis in the past, occasionally hearing voices when he was drinking, but there was no evidence that this happened during his actual index offence. He struggled with cutting down with his alcohol. What would happen is he would manage to quit for a couple of weeks or maximum a few months at a time, but would invariably relapse, which fits in exactly with the features of alcohol dependence, which I told you about earlier. So in my report, I did a risk assessment, and I noted that Mr. B showed great engagement with a number of rehabilitation programs whilst he was in prison. So that included anger management, and he also did an alcohol and offending and an enhanced skill modules. What was interesting about his behaviour is that Mr. B would go for a couple of years at a time in prison without any kind of concerns, no kind of boundary breaches, and then suddenly he'd be caught with a positive urine test for cannabis. So it sounds like he wanted to stay well and to behave himself, but impulsively he would break the rules. In terms of his risk assessment, I noted that there was no direct link between his mental illness and his previous offending. For example, he wasn't suffering from hallucinations or delusions that compelled him to commit violence or compelled him to kill his cousin. But there was an indirect link, with alcohol being the confounding factor. And that was caused by his social anxiety and low self-esteem. So he drank heavily in the past, and that influenced his offending. So what I opined in my report was that Mr. B needed to be tested with the temptation of alcohol, and he needed to have a number of ROTLs. Those are ROTLs. They're called Release on Temporary License. And that's an important part of the resettlement and rehabilitation process for prisoners. Basically, it's like temporary leave from the prison. Initially, they start with resettlement day release and then later overnight. And not too dissimilar to what happens with patients in psychiatric units like where I've worked. I also thought that Mr. B would need a high level of supervision and restriction from probation services after he was released from prisons. Obviously, I suggested that he should tie in with alcohol services such as Alcohol Anonymous, and also one of his conditions would have to be prohibition, so he couldn't actually use alcohol and he couldn't buy it. I didn't think Mr. B needed the input of the community mental health team because, to be honest, mental illness was very insignificant in his overall risk assessment. It was all about the booze. So reflecting on Mr. B's case, what really struck me about it was that Mr. B wasn't actually really that dangerous of a person, at least compared to many other defendants that I've assessed. It was just that on that one particular night, on that one particular incident, he drank too much, he got provoked, and he did something impulsive and stupid that changed his life forever and ended his cousin's life. After the break, I'm going to tell you how to make prison hooch in case you ever find yourself in prison and you want a bit of a tipple. Okay, so prison hooch, how do you make it? At least, how do you make it in the UK? So you need lots of oranges, you need lots of sugar. Put them all together, then you add a ton of lemon drops. And then you also need a kicker. A kicker is a fruit that's already rotting and fermenting. And you also put in non-caffeinated soda. You put all of that into a big container and you've got to keep it hot continuously for 3 days. And after that, you've got to burp it every hour because there's so much gas that you don't want it to explode. It's much like burping a baby, I hear. Now, I've never actually burped prison hooch, but I have burped some babies. Specifically, I've burped 2 babies in my life. Both of them were my sons. And after all that, voila, you're left with what to me sounds like an absolutely disgusting drink, which can get you drunk. But it can also get you very ill, so it can even give you botulism. No thanks, I think I'll stick to my White Russians and my freedom. Thank you very much. All jokes aside, if you need help with alcohol problems, then you should look at the links below that are in the comment section. Before we finish, I've got some questions for you, dear viewers. I'm genuinely really intrigued to know if any of you have ever tried prison hooch, and if so, what it tastes like. If you or anybody that you know suffered from withdrawal symptoms or even seizures. If you have, please tell me. Okay, I'm going to tell you about the next episode, but before then, I just want to tell you very quickly that I'm excited to share some news with you guys, which is this. I'm going to be a speaker at CrimeCon UK in June 2021 in London. It's a massive convention, it's really popular in the States, and it's coming to the UK. If you are truly a true crime enthusiast, then you cannot miss out. There's a link in the descriptions of how to get your tickets. If you use the code PSYCH, then you'll get a 10% discount because I've got you. So look out for part 3 of my series on alcohol, and I'm going to be talking about alcohol's association with offending and when it can be used as a psychiatric defense if you're on trial for a crime and you're drunk at the time. So please subscribe to our YouTube channel. Not only does it help me out immeasurably, but it actually automatically makes your shirts less crumply so you don't look like such a tramp at work. Comment more please on my videos. Some of you have reached out recently and I've enjoyed having a bit of chat with you. I'd like to engage with my viewers more because I love you all. So reach out, follow us on Instagram, like our Facebook page, submit an episode idea or any questions to our email, which is psychforsore@gmail.com. If you're going to reference us, use #PsychSore. Please tell your favourite people about Psych for Sore Minds. They deserve it. Spread the love. Until next time, stay euthymic and remember, I love you. That's enough for now.